Welcome to this explainer. Today, we're opening up a true medical rogues gallery. We're going to brief you on some of the most fascinating, bizarre, and honestly, dangerous parasitic villains in all of medicine. Human cestodes. You probably know them better as tapeworms. We'll systematically break down their profiles, their modes of attack, and exactly how we track them down and target them clinically. So grab a pen or just get ready to take some mental notes because we are diving right in. Here's our agenda, basically our wanted poster lineup for today. First, we've got pork versus beef tapeworms. Second, the brain invader. Third, the cyst builders. Fourth, we'll do a rapid cestode review. And finally, exam traps and takeaways. All right, section 1, pork versus beef tapeworms, specifically Taenia solium versus Taenia saginata. Now, what's really interesting here is how the physical weapons of these two parasites completely give away their identity. Taenia solium, that's the pork tapeworm, comes quite literally armed. It's got this armed rostellum with 2 rows of vicious little hooks right on its head, or scolex. Now contrast that with Taenia saginata, the beef tapeworm. It's totally unarmed, no hooks at all, just 4 prominent suckers to latch onto its host. Even their internal anatomy is a dead giveaway. Solium has a smaller number of lateral uterine branches, usually between 8 to 12, while saginata is absolutely packed with about 15 to 30 of them. Now, before we go any further, I want to throw a high-stakes clinical scenario your way. It's actually one of the most common traps in medicine. Does eating undercooked infected pork cause brain cysts? Take a second, really think about what you've learned or heard about this one. The answer is a resounding no. There is a huge misconception out there about this. Eating undercooked pork that contains cysts will only give you an adult intestinal tapeworm, a condition we call tinniasis. So you might be wondering, how do the cysts get into the brain then? Well, it happens when a human ingests the actual eggs of Taenia solium. This is strictly a fecal-oral route situation. For example, a person carrying the adult tapeworm passes eggs in their stool, those eggs get under their fingernails, and they end up infecting someone else's food, or literally reinfecting themselves. The eggs hatch, the larvae migrate into human tissue, and that is what causes those incredibly dangerous cysts. Which brings us right to section 2, the brain invader, neurocysticercosis. This particular invader doesn't just attack randomly. It has specific hideouts in the brain, and each one triggers a unique clinical nightmare depending on the body's inflammatory response. So, if the cysts lodge in the brain parenchyma, that's the actual brain tissue, the most common manifestation by far is seizures. But if they float into the ventricular system, they can act almost like a ball valve, physically blocking your spinal fluid and causing obstructive hydrocephalus. Sometimes this is called Brunn's syndrome, especially when symptoms change based on the patient's head position. And finally, if they settle down in the subarachnoid space or the basal meninges, you're looking at severe complications like chronic meningitis, vasculitis, and even stroke. And here is a brilliant illustration of the exact visual fingerprint that catches this parasite red-handed on a scan. It's known as the dot and hole sign. When you look at a CT or an MRI, you literally see this dark, fluid-filled cystic lesion. That's the hole. And right inside it, there's a bright mural nodule, the dot. You know what that dot is? That is actually the scolex, the head of the parasite, staring right back at you. When you see this on a scan, it is totally pathognomonic. You've got your diagnosis locked in. So the absolutely crucial point here is mastering your rules of engagement, because if you attack this parasite the wrong way, you can literally kill the patient. Look at these strict life-saving rules. Rule number 1, never start antiparasitics if the patient has elevated intracranial pressure. Why? Because killing the parasite right then and there triggers a massive swelling cascade of inflammation. Rule 2 goes right hand in hand with that. Always give glucocorticoids, something like dexamethasone, alongside your antiparasitic drugs to blunt that dangerous inflammatory response. And rule 3, if the cyst is intraocular, meaning it's inside the eye, you never, ever use drugs. The inflammation would cause irreversible blindness, so it requires surgical removal only. Now, when it actually is safe to use our pharmacological weapons, the protocol escalates based entirely on the sheer number of invaders. If your imaging shows just 1 or 2 parenchymal cysts, your first-line treatment is simply albendazole by itself. But if you're dealing with a much heavier burden, say more than 2 cystic lesions, we have to step it up to a combination therapy. You hit them with albendazole plus praziquantel to effectively clear out that infection. All right, moving on to section 3, the cyst builders. This covers echinococcosis, otherwise known as hydatid disease. We're actually tracking two distinctly different cyst builders here. Echinococcus granulosus is the culprit behind cystic echinococcosis. Its definitive hosts are domestic dogs, and what it does is build these unilocular, well-defined, fluid-filled cysts, usually ending up in the liver or the lungs of the human, who is just a dead-end host. Now, contrast that with Echinococcus multiloculars. This one causes alveolar echinococcosis, and honestly, it is terrifying. Hosted by wild canines, foxes and wolves, it doesn't just build a neat little balloon. It builds multilocular, highly invasive and infiltrating cysts. It literally acts and spreads like a malignant tumor, aggressively destroying the liver as it grows. For Echinococcus granulosus, the huge diagnostic clue lies right inside the fluid of the cyst itself. I want you to focus on this highly evocative term, hydatid sand. If you sample that cyst fluid, you're going to see a sediment that looks exactly like fine grains of sand. But this sediment is actually made up of thousands of microscopic protoscolices and brood capsules. Finding this hydatid sand is completely pathognomonic for E. granulosus. There is no mistaking it. But you have to tread so carefully here. You absolutely cannot just blindly stick a needle into one of these cysts. A ruptured hydatid cyst dumps a massive amount of highly antigenic protoscolex fluid straight into the patient's body cavity. This triggers a massive, life-threatening type 1 hypersensitivity reaction. We're talking immediate anaphylactic shock. Plus, secondary cysts can seed everywhere. It's a real nightmare scenario. Because of that huge anaphylaxis risk, we use a very specific, highly controlled procedural takedown called PAIR. Step 1 is percutaneous aspiration, just pulling out a bit of the fluid. Step 2 is the installation of scolicidal agents. These are substances that kill the parasite instantly on contact to totally neutralize the danger. And step 3 is the reaspiration of those now sterilized contents. And hey, remember, you must always bracket this whole procedure with albendazole. You give it for days before and weeks after just to prevent any rogue dissemination of the parasite. Okay, time for a lightning round. Section 4, the rapid cestode review. Let's look at dwarf, fish, and dog tapeworms. We've got 3 more bizarre tapeworms to quickly profile for the gallery. First up is Hymenolipus nana, the dwarf tapeworm. So what's its unique MO? Well, it is actually the most common human cestode, and that's because it's the only one that requires absolutely no intermediate host. None. It spreads directly from person to person and can even auto-infect the exact same host. Next on the list, Diphyllobothrium latum, the broadfish tapeworm. You pick this one up from raw freshwater fish, and its signature crime, it steals your vitamin B12, causing pernicious anemia. Finally, we have Dipylidium caninum, the dog tapeworm. Humans, usually little kids, get this by accidentally ingesting infected dog or cat fleas. Its signature clue is passing segments in the stool that look exactly like grains of rice. But the good news? Notice how all 3 of these fall to the exact same treatment, praziquantel. I want to pause on that broad fish tapeworm for just a second, though, and show you this staggering number, 25. That is 25 meters. That is the massive length that Diphyllobothrium latum can actually reach inside the human intestine while it's busy stealing all your vitamin B12. It is literally the longest human tapeworm in existence. Just wild to think about. Let's pull all this together, Section 5, exam traps and takeaways, covering those high-yield clinical rules. Here's your rapid-fire review of the features that consistently trick students and clinicians alike. Remember this, the pork tapeworm, Solium, is armed with hooks. The beef tapeworm, Saginata, is unarmed. Never forget that cystic comes from ingesting eggs via the fecal-oral route, not from just eating undercooked meat. Keep in mind that E. multilocularis, the fox tapeworm, behaves almost exactly like an invasive cancer, which means those patients often require albendazole indefinitely. And finally, H. nana stands totally alone as the tapeworm that needs 0 intermediate host, making it capable of dangerous autoinfection. Moving right along to our pathognomonic imagery and the golden rules of medical treatment. For neurocysticercosis, seizures are your #1 red flag. Visually, if you see that dot and hole sign on an MRI, you have successfully diagnosed T. solium cysts. If you aspirate fluid and you see hydatid sand, you've absolutely nailed an E. granulosus diagnosis. And for your pharmacological arsenal, broadly speaking, all cestodes are treated with praziquantel. You just have to remember that cyst and alveolar disease rely heavily on albendazole instead, and fasciola, which is technically a trematode anyway, is your major exception to the praziquantel rule. Which brings us to our final thought. The mechanisms of these parasites are incredibly complex, and their ability to hide and destroy is profound. But, as we've seen today, they all leave clues, whether it's vicious little hooks, microscopic sand, or a bright dot in a hole on an MRI. So when a microscopic invader breaches the body's defenses, is your medical knowledge armed and ready? Use the structured clues from this explainer, track down the evidence, and you'll be more than ready for whatever medical mystery you encounter next. Thanks so much for joining me on this deep dive.